PowerPoint slide number 1. Our biomedical integration group consists of Richard Anderson, Jaleesa Bradley, Kiara Drew, Mia Holmes, Keitra Riggins, Kimberly Tavares, Sedalia Reed, Christopher Varghese, Lauren Carter, and Jeremiah Taylor. Our group is responsible for the following aspects of the case: microbiology, oral pathology, and practice management. The students responsible for microbiology are Keitra Riggins, Kiara Drew, Christopher Varghese, and Mia Holmes. Responsible for oral pathology is Sedalia Reed, Kimberly Tavares, and Jaleesa Bradley. Responsible for practice management is Richard Anderson, Jeremiah Taylor, and Lauren Carter. This slide number 3 is a quick review of our patient history. We have a 45-year-old male opera singer. Has pain in the left posterior maxilla, a bad taste and a yellow-white discharge for the past year. He was told that his third molars needed to be extracted due to periodontal disease. Headaches and mid-face pressure. A panoramic x-ray showed cloudiness in the left maxillary sinus area. A PMH, heart disease, essential hypertension, asthma, obstructive sleep apnea. His past surgical history is an appendectomy, a tonsillectomy, surgical exploration of the abdomen secondary to adhesions. His allergies consist of penicillin and ephedrine. The social history is tobacco use of 1 pack per day for 25 years, IV drug abuse, no BCP but IUD. His religion is Roman Catholic. Slide 4 discusses the microbiology. Sinusitis, due to the headaches, mid-face pressure, and cloudiness. Endocarditis, due to the heart disease and the prosthetic valve. Periodontal disease, which would be generalized chronic, due to the yellow discharge and pericarditis. And asthma. For each topic in microbiology, we will discuss what the condition is, which microorganisms are involved, how one would culture the organisms, and how the organisms appear microscopically, and the treatment for each bacterium, virus, or fungus. Slide 5, we will discuss asthma. There are many causes of asthma, including family history or exposure to cigarette smoke. We will analyze a microbial cause, which is due to a viral infection. Virus-induced asthma refers to inflammation and constriction of the airways that is triggered by a viral respiratory infection. Common respiratory viruses include rhinoviruses, human respiratory syncytial virus, adenoviruses, coronaviruses, and influenza viruses, as well as some bacteria. The appearance: rhinovirus is a single-stranded positive sense RNA virus that is naked and icosahedral in shape, about 30 nanometers in diameter. Cultured organisms. Viral culture is a test in which samples are put with the cell type that the virus can infect. The sample is centrifuged. The growth is measured by antigen detection. The treatment. At present, there are no effective medications to treat these common viruses and prevent asthma attacks. The best treatment is prevention with a flu shot. Treatment for a viral-induced asthma attack may include bronchodilators. In slide 6, we will discuss the periodontal disease. Pericarditis, an acute infection with clinical symptoms including pain, swelling, erythema, and purulence are not uncommon. The bacteria most commonly detected are alpha-hemolytic streptococci and the genera Prevotella, Veillonella, Bacteroides, and Capnose cytophaga, all of which can be detected in the gingival crevice surrounding third molars or adjacent teeth. The microbiologic flora associated with pericarditis is diverse, including obligate anaerobic bacteria and facultative anaerobic microflora, which result in suppurative infections. Pericarditis can progress to significant life-threatening infections. Accepted treatment regimens include antibiotic therapy coupled with surgical intervention. Surgical removal of the tooth associated with the infection is curative. Slide 7 is a continuation of periodontal disease. Increased periodontal probing depths, in addition to periodontal attachment loss, in addition to the colonization of periodontal pathogens, support the concept that clinical and microbial changes associated with the initiation of periodontitis may present first in the third molar region. Chronic oral inflammation leads to periodontal disease progression in the third molar region over time. Pathology, as detected by these measures, exists in the third molar area without symptoms noticed by the individual affected. In slide 8, we will discuss sinusitis. Sinusitis, also known as sinus infection, is inflammation of the sinuses resulting in symptoms. Its etiology may be viral or bacterial. If the infection is acute, it is often viral in origin. If the infection is chronic, bacteria is the suspected causative agent. The patient is likely suffering from a chronic infection as his symptoms align with the following. Symptoms last over 10 days. Fever, discharge, and facial pain, worsening pain and nasal discharge, and a cloudiness radiographically. Based on his presentation of pain from an untreated tooth for over 1 year, discharge and headaches, we will conclude that he is suffering from chronic bacterial sinusitis. The bacteria involved in this infection consist of anaerobic and aerobic bacteria. Which were detected in conjunction with chronic sinusitis. Also isolated are Staphylococcus aureus, including methicillin-resistant Staph aureus, and coagulase-negative Staphylococci, and gram-negative enteric organisms can be isolated. Treatment for bacterial sinusitis consists of a narrow-spectrum agent that covers Staph pneumoniae and H. influenza. Amoxicillin is preferred. A second line may be used if not effective within 72 hours. Symptoms may also be alleviated with nasal decongestion, nasal corticosteroids, and pain relievers. Slide 9 is a continuation of sinusitis with a chart that displays the characteristics of the bacteria involved. This chart further outlines some important characteristics about bacteria involved in chronic sinusitis. All of the involved organisms have a cocci morphology. Also, all organisms are either aerobic or facultative anaerobes, since the environment of the sinus contains oxygen. Slide number 10 discusses endocarditis. Endocarditis is an infection of the inner lining of your heart, the endocardium. It generally occurs when bacteria or other germs from another part of your body, such as your mouth, spread through the bloodstream and attach to damaged areas in the heart. Left untreated, endocarditis can damage or destroy the heart valves and can lead to life-threatening complications. Staph aureus, commonly found on the skin, and viridin streptococci are common organisms frequently associated with endocarditis. A few less common but possible other culprits include Haemophilus, Actinobacillus, Cardiobacterium, Echinella, Kingella, and Staph epidermidis. Blood cultures can be used to identify the specific organisms associated in a given case. Some characteristics of the more common bacteria include Staph aureus appears as gram-positive, cluster-forming coccus. It is non-motile, non-spore-forming facultative anaerobe, catalase-positive, and coagulase-positive. It appears as a golden yellow colony on agar. Viridin streptococci are gram-positive cocci, catalase-negative, alpha-hemolytic, and opticin-resistant. Its water-insoluble glucose polymer, either dextrin or glucan, enhances adherence to enamel surfaces. Transient bacteremia allows colonization of damaged heart valves. Endocarditis caused by Staphylococcus can be treated with rifampin plus a beta-lactam antibiotic or vancomycin. Those at highest risk of endocarditis today, antibiotics before dental procedures are only recommended for patients with the highest risk of infective endocarditis. Slide number 11 discusses the oral pathology and the pathogenesis of periodontal disease. The current view is that inflammatory periodontal disease begins with gingivitis and may progress over time to periodontitis due to proliferation and apical migration of the epithelial attachment, junctional epithelium, with pocket formation. Slide number 12 discusses oral pathology and the major forms of periodontal disease. Gingivitis, when the inflammatory process is confined to the gingival tissues. And periodontitis, when inflammation progresses into the supporting structures, resulting in attachment and bone loss. This ultimately results in tooth loss if left untreated. Slide number 13 discusses oral pathology and the periodontal pocket formation. So we start with the healthy sulcus, then we can get microbial plaque accumulation, which is either supragingival or subgingival, which can lead to inflammation of the gingival tissue, which can next develop into widening or enlargement of the gingival sulcus. We can then get a pseudo pocket formation. And next, we will have inflammation and lysis of connective tissue and the apical migration of junctional epithelium, which can develop into periodontal pocket formation. Slide number 14 is a continuation of oral pathology in which we will discuss gingivitis. As stated before, the formation of periodontal disease begins with an inflammatory disease known as gingivitis. Gingivitis requires the presence of bacterial plaque, which is thought to induce both indirect and direct pathological changes in the periodontal tissues. It is characterized by gingival redness, edema, bleeding, changes in contour, for example, rolled or enlarged margins, loss of tissue adaptation, and increased flow of gingival-clavicular fluid. Histopathologic changes noted in gingivitis have led to 3 subdivisions based on these observations. Slide number 15 is a continuation of oral pathology in which we will discuss the initial lesion. The first subdivision is known as the initial lesion. In this stage, no clinical changes are evident. The acute inflammatory response is characterized by infiltration of neutrophils. Other observations are dilation of capillaries and increased blood flow, which leads to the ease of bleeding. Changes in this stage is most likely due to chemotaxis of PMNs in response to bacterial factors, direct vasodilatory effects, and activation of host complement and kinin systems. How the host responds to bacteria at this time is very critical in determining whether the host will return to a state of health or whether the disease will progress. Slide number 16 is a continuation of oral pathology in which we will discuss the early lesion. Following the initial lesion is the early lesion. At this stage, erythema, which includes redness around the gingival margins, and bleeding on probing can be clinically observed. The cellular infiltrate in the early lesion is dominated by T lymphocytes. Cytotoxic changes in fibroblast activity lead to a reduction in collagen formation and increase in collagen destruction. Junctional epithelium may begin to show development of ready pegs and ready ridges. Slide number 17 is a continuation of oral pathology in which we will discuss the established lesion. The established lesion is the final stage before progression into periodontal disease, which affects supporting structures, i.e. bone and not just gingival tissues. At this stage, the gingiva appears bluish red or purplish due to gingival anoxemia. Gingival anoxemia is defined by decrease in blood flow or when the blood flow becomes sluggish. Blood vessels become engorged and the breakdown of hemoglobin causes an increase in erythema. There is a predominance of B cells and plasma cells along with increased collagen breakdown due to increase in collagenase activity. Slide number 18 is a continuation of oral pathology in which we will discuss the advanced lesion. The advanced lesion is also called a periodontal pocket or true pocket. This is the result of periodontal breakdown due to periodontitis. In periodontitis, the attachment apparatus is destroyed, specifically gingival connective tissue and periodontal ligament fibers, and cementum becomes exposed to the oral environment. Bacteria are then able to penetrate the cementum. Histopathology involves the extension of the lesion into the alveolar bone, loss of connective tissue attachment, and the domination of B cells and plasma cells and infiltrate. Slide number 19 is a continuation of oral pathology in which we will discuss the pathogenesis of periodontitis. According to the informational paper, Pathogenesis of Periodontal Diseases, prepared by the Research, Science, and Therapy Committee of the American Academy of Periodontology. Periodontitis is clinically differentiated from gingivitis by the loss of the connective tissue attachment to the teeth and the presence of concurrent gingival inflammation. Loss of the periodontal ligament and disruption of its attachment to cementum, as well as resorption of alveolar bone occurs. Together with loss of attachment, there is migration of the epithelial attachment along the root surface and resorption of bone. The histopathology of the periodontitis lesion is in many ways similar to that of the established lesion of gingivitis, with the predominance of plasma cells, loss of soft connective tissue elements, and in addition, bone resorption. Slide number 20 is a continuation of oral pathology, in which we will discuss the pathology of oral antral communication. The patient's chief complaint was associated with his upper left third molar, tooth number 16, and his signs and symptoms included mid-face pressure and cloudiness in the left maxillary sinus. During the extraction of number 16, the case stated that a large piece of bone posterior to the tooth was also removed. Unfortunately, this led to a whistling sound when the patient had to perform at the Metropolitan Opera. The most logical reason for the patient to have that whistling sound, using all the information provided, is that an oral antral communication was created after number 16 was extracted. The patient was not informed that this had occurred, and it also seems like the dentist did nothing to correct the issue at the time that the bone was inadvertently removed along with the tooth. According to Nezafati et al., oral antral communication, or fistula, is common following the removal of posterior maxillary teeth because of their close relationship to the maxillary sinus. Surgical closure of an antral perforation is indicated if the opening is greater than 4 to 5 millimeters at the time of injury. If a sinus disease is present, whatever the size of the opening, and if the communication is persistent. The most common surgical technique for closure of an acute oral antral perforation is the buccal flap procedure described by Remen. Great care must be taken to develop the flap with correct undermining and horizontal periosteal releasing incisions to create a watertight closure without tension. Slide number 21 is a continuation of oral pathology and the oral antral communication. According to Rothamel et al., oral antral fistulas are the most common dentogenic cause, including 56 to 70%, for the development of maxillary sinusitis. 20 hours after an oral antral communication has been created, inflammatory infections of the mucosa of the sinus became evident in 3/4 of cases. In a study of patients with persistent infections, the most common radiological feature was polyps with mucosal thickening. In this case, since the sinus infection was present before the oral antral communication was created, then it can be assumed that the odontogenic infection associated with tooth number 16 spread to the left maxillary sinus because of the proximity of the roots to the floor of the sinus. Slide number 22 is practice management. Practice management involves the entire dental team. This includes the front desk, finance team, dental hygienist, dental assistants, and the dentist. There are many jobs and details that compose the dental team, but it is essentially the job of the dentist to ensure that all of these aspects come together to provide the best possible care and treatment options for every patient. Slide number 23 is a continuation of practice management. It is imperative that proper measures are taken in order to do what is best for the patient. This includes, but is not limited to, taking a thorough medical dental history, properly informing the patient of the procedure, in layman's terms, obtaining informed consent. Prophylactic measures are taken if indicated, informing the patient of any complications that occur during the procedure, in layman's terms, and giving thorough post-op instructions, in layman's terms. Slide number 24 is a continuation of practice management. The mistakes made in this case include: the dentist did not obtain the medical consult, did not obtain a thorough past medical or dental history, did not prescribe antibiotics, did not inform the patient of the complications that occurred during the procedure, and did not properly explain post-op instructions. Slide number 25 is a continuation of practice management. The dentist is legally obligated to take all measures necessary to ensure that no harm is done to the patient, the patient's best interest is always at the forefront of treatment, and the patient understands their financial and compliance obligations of treatments rendered. Slide number 26. This is the conclusion of our presentation. Following our references.